Boston Scientific never showed up. These people are horrible. I would never, ever get a stimulator from this company. Their customer service alone is a no. Just no. I
Okay, that's
mean,
positive. There's a lot to unpack there. Hello, everyone. Welcome back. Dr. Leake here with our guest, Keith, from representing a group called The Invisible. Well, we call them The Invisibles, but actually it's Invisible No More.
Invisible No More.
Which is the whole goal here is to bring some education, some discussion at the table so that not only can doctors understand pain patients better, but also patients may understand what's going on behind the doctor's scenes, and we can work together to improve everybody's health.
Yeah, how do we can work together to get better care? Because we all want to get better. And whether it's a little bit day by day or it's instantaneous, we all just want to be better. And we have to have that communication.
Absolutely. Yeah. Well, and pain management is such a convoluted world. There's a lot of controversy behind it. And I think that stems from all levels of care, from the federal government to the individual patient. And so, again, this is an opportunity to kind of clear the air on what we can and hopefully come to a mutual agreement, discussion, conclusion to benefit all of you guys who might be watching this.
Even if we don't agree, at least we understand where the other person is. And I think if we have that better understanding, I still think we can work together to get better care.
Absolutely.
As the goal.
So today's topic is spinal cord stimulator.
Oof. and I've told you that vast majority of the people that I talk with that deal with chronic pain are very vocal about nerve stimulators.
Yeah.
And they're not vocal in a really positive way.
Absolutely.
That too. Yeah. Because there's been experiences, and I've told you that it's like a third rail. You don't want a lot of doctors don't want to even touch the topic of it, and they're just glad to hear a professional, a doctor, a pain doctor, acknowledge, hey, nerve stimulators. This is what's good. This is,
sure.
And that's just shocking to a lot of people in the community. So thank you for.
No, absolutely. And for all the people that are waiting to comment, but he gets paid to do stimulators. Yes, I do. But I also get paid to write prescriptions, and I get paid to send referrals, and I get paid to do a lot of things. I'm a pain doctor. What do you want from me? So I can't fully separate that. But my goal is to answer the questions that a lot of people have, share with you some experiences that I have with my patients. And, I think I was talking with a retired emergency physician actually the other day, and I wanted to get his opinion on spinal cord stimulators. And he's very against them. He's like, no, I would never touch those things with a 10-foot pole. And I was like, of course you wouldn't, because you see all of the bad cases filter through your practice in the emergency room. So I think that's maybe part of it. Generally speaking, I think, most people would agree the squeaky wheel gets the grease. The most dissatisfied patients are going to be the most vocal about it. You're never going to hear, we try to get them to leave us some reviews, but generally you're not going to hear about successful cases.
And you're exact. I experienced that.
Mm-hmm.
I have a lot of people who've had negative experiences, but those voices drown out the positive one. Right. And it's almost like, I don't want to say bullying, but people who have had a positive experience don't want to speak up because they see so many having negative experiences. They don't want to be like an oddball, or like they don't want, well, just wait, it's going to happen, when it's actually helping them. So I get a lot of private messages, a lot of texts, a lot of phone call. Hey, I saw you guys talking about this. You need to know it works for me.
Right.
And so I'm not totally against them.
Yeah.
For people. I want whatever works best for somebody to get better.
Yeah.
But there are some cases where, things have gone maybe sideways.
Yeah.
Is it a polite way?
It's not for everybody. And I think that, maybe one of the conclusions that we come to in today's meeting, and just like, we have lots of tools in our tool belt. And I think that, we were talking about this a little bit earlier. I think the pain community at large may have a tendency to self-cannibalize in some sense if a treatment doesn't necessarily work for them, they think it should be pulled off the market.
Oh yeah.
And nobody should have it.
Yeah.
And I don't think that's going to be very helpful for anybody.
No, and that's one of the things we were talking earlier, that as Invisible No More, we work really hard in trying to shift the community's viewpoint. That even if you've had a bad experience with the stimulator or gabapentin or something, and don't come out and tell people not to try it, because it actually may be what saves them.
Right.
And if you're telling them not to do it, they're going to listen to you and they're not going to do it. And you're basically saying, stay home and suffer, then try something else.
Yeah.
And if it works for somebody, whether it was bad for us, I think it was bad for us, we need to celebrate what works for other people.
Absolutely.
And we're working really hard to get that shift to where people are celebrating other people getting better, because that's the key. What can we do to try to get better? So
couldn't have said it better myself. Yeah. So, when it comes to stimulators, there is a lot of bad press, and I do find myself when I come to talk to a patient about it, in most cases, not every case, but a lot of patients have already had back surgery. They've done the injections, they've had the back surgery, they have all this hardware in there, and they still have pain. That's an indication for a spinal cord stimulator. We call that failed back surgical syndrome. It has its own diagnosis code. Yeah. And there's a lot of physiologic reasons that, we don't have to get into in today's conversation why that's the case. You still have pain after everything's been decompressed and stabilized and all that good thing. But yeah, they still have pain. And so in most cases, that would be a great candidate for this type of therapy. But because of the negative press that's been out there, or they had a family member or a friend that had it and didn't work, let's say, they come into it saying, that sounds really invasive. Doesn't sound like it's for me. I think I'm just going to go back to my surgeon and have them fuse another 3 levels. And it's like, bro, that's way more invasive than just trialing a stimulator, So I think to set the ground straight, we should talk a little bit about what that procedure is, what it looks like. And Kevin, I think you may have an animation for us. Yeah.
Yes, sir.
Okay. So we're gonna plug that in and take a look at that now, so you can see what that looks like.
Here's how SCS works. When you feel pain in your back or leg, here's how SCS works. When you feel pain in your back or leg, for instance, it's because nerves from that part of your body are sending pain signals through your spinal cord to your brain. SCS is designed to interrupt those pain signals using a small device called a stimulator and thin insulated wires called leads. The stimulator generates mild electrical pulses that travel through the leads to nerves in your back, interrupting the pain signals before you sense them.
Okay. So yeah, no, essentially, there are certain indications for this type of procedure. Some of the most common ones would be failed back surgical syndrome. Similarly, we can do that in the neck for the same sort of scenario. Persistent lumbar radiculopathy, which is a fancy word of saying sciatica, or nerve pain that comes out of the spine into the extremity, arm or leg. Another common one is complex regional pain syndrome. So these are some of the most common indications. There are other indications, diabetic peripheral polyneuropathy, right? So neuropathy, maybe due to diabetes. So those are some of the things that we can use this therapy for, and it's been studied for quite a while. A lot of really good outcomes for the right patient that we're experiencing. So to kind of break it down, I think a big part of why this treatment works or it doesn't work is, again, finding the right patient. And that's the key. And that's across the board for every tool that we have in our toolbox, right? There's 100 different medicines. There's 100 different ways of doing therapy, laser, chiropractic, dry needling, you name it. And not everything's going to work for everybody. So this is just another example of that. To further that concept, there's basically 3 different types of pain. Okay, so there's nociceptive pain, which it describes sort of the normal physiologic process that if you hit your hand on the table, it hurts, right? That normal healthy process is referred to as nociceptive pain. Then there's neuropathic pain, which describes more pain related to neuropathy. And then there's nociplastic pain, which is reserved for syndromes such as fibromyalgia, or centralized pain syndromes such as that's where the physiology of the pain is located primarily in the brain or the spinal cord. So those are the three big categories of pain. Spinal cord stimulator really only works for the latter two, neuropathic pain and nociplastic pain. So you can imagine if you did a trial and it didn't work, it may not be one of those pain syndromes. You may not be the right person for it, but that doesn't mean the therapy is not good.
Right.
So that's what I'm trying to illustrate. Now, if I were to go work for somebody else as an employee, a physician in a bit larger group, let's say, everybody has different protocols. But from what I'm hearing, the standard of success is the threshold is a little bit lower, right? Because clearing the air, there's an incentive to do these procedures. And to be fair, these are some of the only procedures that are still paying anything. When it comes to injections, for example, I hear a lot of times from patients, my doctor's doing all these injections. He just wants to make a whole bunch of money. I hate to break it to you, but actually there's more money to be made seeing you in clinic, writing you a prescription, than taking the risk of putting a needle in your back and all of the insurance authorization that goes. No, there's no money in injections. To be fair, there's still money in stimulators. Yeah. Okay. But you still can't be doing it for everybody because eventually you will be audited and you will be cast out of everybody's network. So that you still have to play by the rules. But
you're talking, I want to kind of clarify too, you're talking about good doctors.
I do want to talk about good doctors. Yes. Right. Okay. That is the standard that we should hold ourselves to.
Okay. All right.
So now in my clinic, our success rate for stimulators, meaning that if you had a good response with the trial, you go forward with the permanent and you have a good response with the permanent. That rate is about 90%.
Wow.
Okay. Now, again, people can say I'm saying whatever I want. Obviously, I can't show you exactly my numbers, but it is what it is. Take it or leave it. But the standard, it seems like from even what I've been hearing in the community at large, is that your trial rate should be like 60% success rate. So that means be a little bit more liberal with who you decide to put the stimulator in. Mm-hmm. And, there's reasons for that. They say, well, you don't want to miss anybody that could be a good candidate. I see that. But I think more likely it's just, no, we need to get our numbers up. Right. And so that obviously is a whole nother discussion, but,
we need to have that discussion.
Yeah, let's talk about it. No, absolutely. But in my experience, this technology is fantastic technology, for the right patient.
For the right patient.
With the right pain.
And I think that's the key.
Yeah.
Right? It has to be the right patient in the right situation. And it goes back to where we've talked before about the treating the entire patient and individualizing that plan. Because if you individualize that plan, you know what's working for that patient.
Yes.
And what's not working for that patient versus just assuming, well, you have sciatic pain. Well, this nerve stimulator would take care of that. Well, we tried SI injections and it didn't work. So the only thing that's left for you. And that is a lived experience of mine.
Right.
And so, just get it out. When I went from that doctor to where I'm at now and actually having an individualized plan again, it is night and day.
Mm-hmm.
Right.
Right.
And that's why when I hear stories when it's gone bad, I hurt for people. It's the problem of being an empath. You absorb actually the feelings, right?
Right. Yeah.
But then I hear other people in private messages who don't want to be the only one that stands up. Hey, I'm not getting 100%, but I'm getting like 30 to 50% relief with this thing. So I'm going to call that a win because they realize that 30% is better than 0%.
Right.
And I think that's important,
And it comes back to mindset as well. I mean, that's just true across the board with any treatment in pain management. The longer someone has dealt with chronic pain and maybe has been kind of passed through a negative experience in the pain management world, they become jaded. Patients become jaded. And so they're not feeling like someone's listening. They're not feeling like someone actually cares. And so whatever you have to offer, stimulator, injection, therapy, whatever it may be, there's going to be an immediate distrust that comes across. Mm-hmm. And I think that's justified from the patient's perspective But I also think it's unfortunate. I mean, obviously it is unfortunate, but and I say that because that negative expectation now will negatively impact their outcome.
I'm brutally honest. When I left that doctor, I interviewed three more, and the gut feeling wasn't there. And then I came in here, and the gut feeling was there, and that's when I made okay, I'll do what I got to do. I think Dr. Leake's going to be it for me.
Mm-hmm.
But dealing with the PTSD from that previous experience,
Mm-hmm.
my guard was up.
Yeah.
Guard was up. The nerves before an appointment, throwing up before coming in to make an appointment because I knew what I used to have to deal with versus coming in here. It's like, am I going to have to face this again? So those walls are up, and it's unfortunate that when you find a good doctor, you still have those walls up because of what your previous expectations were.
Right.
So when your previous doctor was saying, well, the SI injections didn't work, so the only thing that's going to work for you is this. And then you come to a place where they start over a few months developing a plan.
Mm-hmm.
It's like, okay, well, maybe he's not just here to do a surgery. And unfortunately, it takes time to get those walls down. And you unfortunately, and the other good, decent doctors, good doctors out there, not even necessarily unicorn doctors, good doctors, right? They have to pay the price of those bad experiences. And I think you're right. I think the wall is up about nerve stimulators.
Right. Yeah.
Because of how they were forced or bad treatment in the past.
Absolutely. And if I have a patient that has heard about a stimulator, in my experience, they're not going to want one. And that's all they've ever heard. They just heard the negative. If I have a patient that has not heard about it, then I can explain the benefits and they're feeling optimistic about it and they'll proceed and be successful. But if I have a patient, that has hesitancy, that is, I'm sure it works, but I'm not into it. I'm not going to push that patient because even if I could tie the stimulator to their opioid prescription, which happens.
Oh, it happens. Yeah. That's one of the hoops
Right?
you have to jump through.
Right. It's one of the hoops you have to jump through. Now, again, there's an argument on the physician side. Well, you can't just write scripts. That's true. And I agree with that. You have to be doing something, but that doesn't mean you have to be doing a stimulator. There's other things to do. But a lot of times that prescription is tied to the stimulator. They do the trial. It doesn't work magically because they didn't want it to work. They were scared. They feel forced. They're fighting PTSD, anxiety, and all the rest. No treatment's going to work under that circumstance, right? And they've studied this. This is proven in the scientific literature. So no, if a patient is not feeling optimistic about it, I won't do it. And if I have a patient that started off feeling optimistic about it, and then I was reading some things, but I still want to do it. No, I'm canceling it. We need to be like 100% on this.
The same page. Yeah, kind of like where we're leading to that end, right?
Right.
But yeah, it's unfortunate.
Mm-hmm.
It's unfortunate for people things have gone sideways and had bad experiences. My heart really aches for them, but at the same time, it's unfortunate that where people who may find it works aren't going to even get to the trial because they hear negative stories.
Right.
And I'm not trying to discount anybody who's had a negative story. I give those people that speak up like that, I give them credit.
Yeah.
Everything good, bad, ugly needs to be shared.
Absolutely.
I just wish I could get people who have had 30% relief to do the same thing. Because
this is a call out to all my patients. Please leave us a review so you can show others how it worked for you.
Please do, because that side of the story needs to reach out to Dr. Leake or me. I'll put you on my lives, and when we launch our podcast, I'll put you on the podcast.
Yeah, talk to somebody else. You don't have to talk to me.
Because like I said, I don't want to discount where it's gone bad, but at the same time, I don't want to tell somebody not to do it if it can actually help them.
And to be fair, this is not you should all go out and get a spinal cord stimulator trial.
No.
And again, it's not for everybody. And there are things that can go wrong. But we're not afraid to talk about it. Actually, we had a patient go sideways on one of these products. And so we're going to give her the stage today and see what she has to say. Kevin, you want to pull her up?
Hey y'all, this is Sarah, CRPS Warrior. I want to hone in today and talk about my spinal cord stimulator. I've decided to go this route because it's what's currently prevalent in my life, an issue that I'm dealing with. But let me give you a little history about myself. I'm a mom of 2 grown boys who are now in college. Super active lifestyle. I was a runner. I graduated from UT. I did all the mom things, all the volunteer things. I've been a stay-at-home mom since I became a mom, and my oldest is 23. If we fast forward to my back issues, they probably started in 2018, 2019, went through all the workup of the ortho, the PT, some injections, pushed into pain management finally. They find that my L4, L5 is herniated, and I have a fusion and discs put in those 2 spots. That surgery broke me. 6 weeks after my first spinal surgery, I was unable to walk. My left leg was herky-jerky, if not just dead. It just fell behind me as I tried to move. Have a CAT scan done 6 weeks after my first surgery. The very bottom screw has fractured my spine. I let the surgeon go back in, back out the screw, and then all hell breaks loose. I do PT for like 8 or 9 months. I was able to finish everything they could, and they couldn't help me any longer. The pain was out of control. When I say the pain is out of control, I was having blow torches from my hip all the way out my toes that were shooting like butane, just flames of butane coming out, uncontrolled, to the point where I was worried I would have a heart attack or stroke out because of how severe this stuff was happening. So those 2 back surgeries in 1 summer, and then about 2 years after that, I got talked into purchasing a Boston Scientific spinal cord stimulator. It was supported by pain management and my surgeon. They were heavily catering to this miraculous device that broke me again. I had it placed in, I want to say, February of 2022. I got about 80% relief with the trial. When I had it implanted into me, I don't think I got any relief ever. So in the last 2.5 years, my battery pack is warm all the time. And then in this past May, it began shocking me from the inside. I reach out to Boston Scientific, no response. Reach out again, no response. Reach out again, no response. I contact 4 or 5 people that are on my care team through Boston Scientific, and one of them responds, and they treat me so poorly through the text messaging system that they have for customer service. Finally, we agree at a time to meet at pain management. I have my appointment at pain management. They never showed up. Boston Scientific never showed up. These people are horrible. I would never, ever get a stimulator from this company. Their customer service alone is a no. Just no. I mean,
that's positive. There's a lot to unpack there.
Well, she doesn't hold back, you know.
As a pain doctor, my initial response was, well, it sounds like she had 2 surgeries that kind of left her in a real bad way, but then she's kind of blaming like the pain management doctor for actually getting her to this point. But it's like, well, she was kind of messed up before. Yeah.
But doesn't that follow, right? She didn't have successful surgeries, so that could lead to where a nerve stimulator could help.
Well, in this case, it seems like she's a little bit jaded. There's no doubt about that. And you know, to Boston's credit, Boston Scientific, actually, they're the only company I use, and the customer service has been fantastic. But I would say a lot of that has to do with the relationship that the physician and their clinic has with the rep. In this case, if she was my patient, I would have actually wanted her to come to me first, and then I facilitate any modulation or correction that needs to happen with the vendor. But, to each their own. But it sounds like she did good with the trial. Something happened with the permanent that did not reproduce that.
Yeah, that's what as somebody who's only licensed to drive a car, that's what it sounds like to me. Something. But are the leads the same?
Great question. Yeah. So they're a little different, but essentially the same. The trial leads are designed. So again, the trial is a 3 to 5 day, maybe 7 day, depending on what your protocol is. But it's basically a week-long trial where it's just 2 needles that go into your back. Through those needles, I would route the wires into the epidural space, same place that you have an epidural injection. And then I would take the needles out, leaving the wires behind. Tape everything down, make it as sterile as we can, waterproof, and then we plug you in and then send you on your way. Now, a lot of patients will have great relief that same day because it's in the right spot based on what we understand about the anatomy and where your pain is. And then now we're stimulating that spinal cord, so we're blocking those pain signals from reaching the brain. But we do a week-long trial because we want to make sure there's no placebo or minimize the risk of placebo. We want to give opportunity for micro adjustments that may be necessary throughout the week. And then, really optimize you by Friday. Let's say if we put it in Monday, to know if this is going to be a good treatment for you. If it is, then we bring you back. Basically the same procedure. We make 2 incisions this time, one up where we put the wires in and one down where we implant the battery. It's very similar to a pacemaker or like the size of an Oreo cookie. And that's what I tell patients sometimes. Think of it like a pacemaker for your spine. Not exactly the same thing, but you get my point. And so it should work. I mean, the conversion rate, it should be near 1-to-1 from trial success to implant success. Now, to be fair, it's 2 different procedures and there's different things that can happen every time you go in. And the wires may not be in the exact right spot. I mean, they may be, a little bit off kilter. So we call that lead migration. Lead migration used to be one of the leading causes of complications and treatment failure for this device. If you think about it, I mean, we have basically 2 long leads and we're floating them on top of your spinal cord. And 20 years ago, that was it, end of story. And so the opportunity for it to slide up and down, move forward or backward was pretty high, about 30%. And based on how concentric and tightly packed the nerves are on your spinal cord, just moving a centimeter can make the difference between pain relief or not. And so that was the big deal. Recently, the technology has advanced so much. The saying is that it's advanced more in the last 5 years than the previous 50 years combined. And a lot of that has to do with the technology itself. So, each lead may have more contacts of electrical output. And then if it does move, we can now control where the electricity gets primarily moved out of. So we can compensate essentially for some movement. Whereas before we didn't have that capacity. And then also the surgical technique has improved. We now are sewing in lead anchors into the back so that it also helps keep everything more rigidly in place. So that 30% failure rate now went to less than 10% failure rate because of lead migration.
Because of migration.
Mm-hmm.
I'm not against them.
No.
I hear Sarah's
Yeah.
Pearl a lot.
Right.
But again, I hear unnamed a lot in private, right? And I guess I can see where maybe the right course would be going to the doc instead of, but then at the same time, I can see being coached. You have a problem, text them,
right.
At the same time. All I can really vouch for is I know she's in a lot of pain.
Oh yeah, no. I'm not trying to dismiss her by any stretch. It's an unfortunate situation,
Yeah.
but yes, I at least how we set things up here, I kind of see myself as the primary care, right? So everything needs to come through your pain doctor. Now, you need to have a pain doctor that's willing to take on that position and a clinic that's capable of taking on that position. If that's not the case, I mean, you just have to understand what you're getting into up front.
Yeah. And again, it goes back to the doctor, right? And the motives behind installing it. And then if it's true motives to install it, I think if you have that gut feeling that it's a true, hey, I really do want you better,
right?
Then I think that success rate can be higher,
right?
Instead of this is the only thing that's going to ever give you relief.
Do you know why that's the case? Because it's often the last treatment of resort.
Yeah, well, I understand. Yeah. Why?
That's a great question. And I don't think it should be for many reasons. I mean, what are your options? They expect you to, well, we have one patient now, Blue Cross is expecting us to do a year's worth of PT first. A year's worth. Now, that's nothing against Blue Cross. I mean, other insurances, they all have requirements before they're going to pay for something expensive. They want to make sure that they've really maximized everything else first, right? And that makes sense. But the system, my point is that the system is designed to make this the last treatment of resort. And I think by that point, so many patients are jaded and the optimism is on the floor. And, and so that does play a role in this. Now, she had a great relief with the trial, but you can tell how she was kind of explaining, I was talked into it. They said this was going to be a miracle treatment and all these things as her experience. And, it sounds like, again, she was apprehensive, but she got talked into it. She was kind of forced into it and unfortunately had a bad outcome. I'm not saying that's all just because she was expecting a bad outcome. It sounds like something went wrong with the device. She was talking about how the battery was getting hot. I don't know what kind of battery she had. I don't know anything about her other than what we just saw.
Yeah. Exactly.
But I do know that rechargeable batteries, they have to be a certain distance from the top of the skin. If they're too deep or really even too shallow, then when you apply the external charger to it, that wireless charger, it can heat up the battery. And I did have one other patient that already had one implanted came to me with that complaint. And we ended up taking it out and replacing it, and he's doing fine now. But, that is something that can occur. I think the breakdown, unfortunately for Sarah, was the communication with the reps, her physician, that only made things worse.
That just made it worse. It all kind of snowballed for her to where now pretty sure she's found a doctor that's going to take it out for her, and they're going to try different therapies to see if there's better ways to get her under control.
Yeah.
I know that with the back issues with her CRPS, I know she's in just in a crazy amount of pain, and when you have pain like that, you have just lived experience. When your pain is out of control like that, there is zero quality of life. There is zero.
Yeah.
And there is, and then for me personally, because I don't want to put words in anybody else's mouth, when it's that bad and the quality of life isn't there, then man, you start going off that cliff.
Right.
And I'm glad Sarah's found somebody now that's going to be able to take it out and find different methods for her.
Right. Right.
But I'm going to say it on record, the fact that you're even willing to acknowledge that sometimes things can go sideways is a major groundbreaking event in the chronic pain community.
I don't understand that, Keith.
It's
nothing's 100%. We should all have that discussion.
See, all the lived experience for me, this is going to solve all your problems. Well, what if this happens? That never happens. It's always a positive. And so you get weeks or months of this is going to be this is what you need. This is what you need. This is the only thing that's going to save you. And then you get 30 seconds before you get knocked out. This may go sideways, but don't worry about it. And that's it. Okay. Because it's like any kind of surgery. Everybody talks about the positives.
Yeah.
Right. And there's very few discussions on, well, if the leads move, something's going to go sideways, we're going to have to go back and fix that. Or if for some reason, when they built this box that's inside of you goes haywire and it starts shocking you, we're going to have to go back in and fix it. Right. That conversation seems to be missing.
Right.
And when I think that's an important conversation to have. A lot of us chronic pain patients, like we talked earlier with Karen, we're not stupid.
Mm-hmm.
We know there can be complications.
Mm-hmm.
And
Yes.
when not high quality doctors, I'm not going to say bad doctors,
Sure.
ignore that,
Right.
then our minds start switching. It's like, okay, well, I'm going to get this done, but he's telling me nothing can go wrong. And so that brings it back to what you're saying. Does that mean, do you still qualify if you're going into it with the bad or apprehensive? What's going to be the outcome?
You know what that sounds like? That sounds like a psyop.
Well, I mean, I've lived through
Yeah.
experiences where that's all that doctor wanted to do.
Oh, well, sure.
And it wasn't because it was necessarily always best for the patient. Because at the time where I was mentally, there's no way that would have worked for me. But
Yeah. No.
but that was still, everything was being directed. That's a whole other video or conversation. But
Sure.
but I'm not the only one that's lived that.
Right.
And so the fact that you're willing to say, hey, sometimes it goes sideways,
Right.
you know. But I've talked to my patients about, hey, you may experience this. If this happens, you need to reach out to me as soon as you can.
Right.
You know, I think having a doctor address it before you start getting weird shocks in your body or you get this warm sensation, I think that is important. And I think in some of the cases that conversation is missing. And I think that's a critical part to making sure that patient is ready to make that step.
Mm-hmm.
I hope that makes sense.
No,
Because
it should be part of the conversation.
because again, we're treating the whole person. And if you leave that set out and then the patient is like, oh, why aren't they telling me any bad things? You're building anxiety, you're building apprehension. And then once it's installed, then you have that battle in their head with it. Right?
I think the knee jerk response from a physician's standpoint is that if I'm explicit with regard to the potential risks, then I'm going to either lose a sale, either from a selfish monetary perspective, but also from a perspective that we believe this treatment will help you. Mm-hmm. And if you say no to it, then it's like you're hurting yourself. There is an altruism to that as well. But also, a lot of patients, pain patients in particular, tend to catastrophize, tend to make things maybe bigger than they are, right? I say that with respect, of course. I mean, I get it.
Oh, there are a lot of terrible pain patients.
Well, and I'm not calling out those patients, but that's just the natural tendencies, especially when you've already been pushed through the system and you're jaded as hell, right? So no, I get all of that. But I think, the knee-jerk response is, as a physician, I need to make this sound very shiny, very hopeful, very optimistic. And generally I do that anyway, because again, it's reinforcing that positive mindset. But at the same time, legally and ethically, we do need to be explaining things appropriately to our patients.
Right.
And not only does that have, those legal and ethical obligations and benefits, but from what I found too, is that if I say, you know what, Keith, like we can put this in and there's going to be a chance that maybe it does this bad thing or that bad thing, but we're going to be watching for it. And if that happens, you let me know.
But see, that's the simple conversation that needs to take place.
But you're not going to be surprised when it happens, if it happens.
Right. And that's it. You take the surprise out.
Right.
But that conversation is lacking in so many instances where this procedure is done.
Yes.
When they're installed. And so when you have, oh my gosh, I'm getting shocked. What the hell's going on?
Yeah.
You
shouldn't be getting shocked.
Yeah, you shouldn't be, right?
Right.
What do I do? Get this thing out of me. Where, listen, this XYZ could happen to you. If it does, you need to be on the phone ASAP so we can get this thing under control and figure out what's going on.
Right.
Okay. So if it ever happens, it's like, okay, oh crap, I got to reach out to my doctor. I'm stopping whatever I'm doing. This isn't normal, right? But at the same time, I think that lessens this isn't normal. Take this out of me. You just get, this isn't normal.
Right. Exactly.
Do you see the difference?
My doctor,
there?
you know, swindled me. He said it was going to be great. And here I am suffering and nobody will answer my calls.
Yeah.
Don't put yourself, other physicians, don't put yourself in that position.
Please don't.
Yeah.
But I think if you compare the just in case,
right.
You get the, oh my gosh, I got shocked. I got to get a hold of Dr. Leake so I can figure out what the hell's causing this, right? Versus, oh my gosh, I just got shocked. They got to get this thing out of me. I don't want this anymore.
What else is going to happen?
Yeah. What's next?
Am I going to be paralyzed?
Yeah.
These are the thoughts.
Let's start building.
Exactly.
Let's start building. So I think that's part of one reason why, you know, and then when you build in social media where my friends do a really good job. And like I've said before, I want people to share the good, the bad, the ugly. But I want them to share good.
Yes,
but
please share good.
They need to share bad and ugly too.
Yes.
So when you're being talked to your doctor about them and they don't mention XYZ, they see somebody on video saying, mine was shocking me. My doctor never told me that could ever happen to me. Do you see those walls going back up? Do you see the success rate?
Exactly.
It's going to just drop through the floor.
Exactly.
But I think if it's prepared right, you know, I think that's, not that anybody wants to get shocked. Not that anybody wants the thing to go.
No, we don't want that to happen.
You know,
yeah.
But at the same time, I think that takes part of it out of the picture. I'm hoping that makes sense because I really feel that's it. I think that's a big change. While they mentioned this, crap, I got to get on the phone, you know, versus what the hell, take this thing out of me. I think that changes the response.
Absolutely.
But that's built on that trust of the doctor saying, you know what, if we're put this in you, this is some kind of the crazy crap that could go wrong. If this happens, you need to find me ASAP.
Yes.
Right.
Right.
And that's a hard conversation to have. I understand because as Dr. Leake, you want that person to get better. So you don't want to scare people off. But I think at the same time, if it's handled right, that's just information. And your patients aren't idiots. They see Sarah's story, right? And if you don't warn them of that, then you get people going, why isn't he telling me something can go wrong?
And that's, you know, one of the reasons I wanted to talk about this. I wanted to have her video on this show. You know, I did a podcast earlier where I had Wayne from Boston Scientific on. And, you know, I don't want that to be looked at like, oh, well, I'm just having reps on and we're just trying to swindle the community into buying our technology. First of all, I don't make money off the sale of the technology. I just get paid to put it in. But I had him on for a reason because, you know, again, he's been excellent with regard to our customer service, making sure our patients are cared for and everyone that he works with, the company at large. I also think they just have the best technology. But I wanted that sort of perspective to be given because I can't give all the details he can give.
I would tell people
that perspective.
I want people to watch that video. Because the technology and what you guys talk about and how things have changed, like since my mom had one 15, 20 years ago.
Oh, it's totally different.
It's totally different.
Yeah.
Right. And how many leads and how many different areas you can treat and how many different, that's all changed. And you guys talk about that.
Right.
Right. And so I think even pro or against stimulators,
be educated.
Yeah. Get the education, watch it, whatever point of view you want, but listen to what can be done now. Because I think there is a big jump in technology from what it used to be. So I would say watch. I watched it, you know. I did admittedly going, crap, he's really talking to a guy about it.
I know. I realized how that looked at the time,
but I'm like, I'm going to sit through it. And I was glad I did.
You know, and again, when I'm talking to patients, that whole conversation happens individually. I'm talking to the patient basically in that way. Wayne's talking to the patient once they get connected in that way, because we do want our patients to be educated and we want them to feel good about the decisions that they're making. You know, we don't do enough stimulators to pay for all of this. It's just not in the cards. So yes, you know, there's obviously incentive there, but there's also an incentive to get better. You know, there's an incentive to free you from medications, whatever those medicines are. Because you don't know what's going to happen next.
No, we already know.
You know?
We already know cuts are coming, right? So we need to find other things to have in our personal toolbox,
right? So
we can either maintain where we are or we can continue to get better. And that's if it's a nerve stimulator or if it's ketamine or if it's acupuncture or whatever. We need to be looking for other things.
Absolutely. Well, those of you in the comments, please add in, join the conversation. If you have any questions, feel free to leave them below. I will answer them. And of course, follow Keith and his group, Invisible No More.
Yep. Go to TikTok and just search #Invisible No More. You'll find us. We'll pop right up.
Awesome. Well, thank you, Keith.
I appreciate your time. Thank you, sir.
Talk to you next time.